here on the stage all the speakers of the day. Join me on the chairs. Guys, please. Thank you. So, as I see, we received a lot of questions from you. Just so you know, you can also vote them, and the questions that get more votes will be on top, so they will be answered earlier. Let's start with the first one, which is for Mr. Lozel, who is no longer with us, but maybe the other speaker who was talking about pharmacy-delivered vaccination could address it. So the question is, do you think eventually pharmacy should replace nurses and GPs as a whole in administering vaccines?
Hi, I talk a little about this. I think that the best solution for the people is if we work together. We can vaccinate or another services. We can do all things quickly, and I think it's more important to decision is for the patient. If I want to be vaccinated on a pharmacy, I have the opportunity to be. But if the nursery center has a service, I can be vaccinated there also. I think if we have to be open-minded for all the professionals, and if we work together for all the things, it will be better for the people. And if it will be better for the people, they will value our intervention. It's not only for the service, but for the communication with the GPs, it's another issue, another important issue. And if we want only for us the vaccination, for example, the GPs will want for them another thing. And if we work together, we can build something better for people. I think, for me, this is the solution.
Thank you a lot. I fully agree with this. Then I see two questions regarding the app, but I don't think we have the speaker here with us, so maybe we can go for the speaker on the bottom, for Maya Sertic. How do you think the alarming rise in mental health issues and already existing issues can be tackled best for the upcoming future?
Okay, thank you for this question. It's a very important one, and I think it's a very difficult one to answer as well. So, I don't know if the person who asked the question would be willing to also engage now and to say, so what do you think are the biggest questions, the biggest issues right now and for the future? So, what do you see the issue is? No one will want to ask you a question afterwards because I'm putting you on the spot.
Okay, 1 minute. Yes, I was wondering particularly about this subject regarding mental health because especially regarding the latest developments in the post-COVID pandemic era, there has been a massive increase in mental health issues, and I think the the fact that the waiting lists for receiving mental health and the mental health awareness and in getting help is still a big problem. And I was wondering, what are your visions on that and how that could be tackled best?
So I'm not a mental health professional, so I just wanted to also state there that, but I think in my personal opinion, the first very important step is that we are talking about it, that we are saying this is an issue and we see it and we try to address it. I think it's very important that we talk about also things like mental health for students, mental health in the workplace. So we can try to tackle these issues, in advance before they become very serious ones, and we take care of ourselves and of each other. But otherwise, I think we should really try to employ also all of the tools we have at hand. And try to merge different services and different professionals bring together. So why not try to use also healthcare apps for this to help people with mental health, to work on prevention, to spread the message. I think in the end the message stays the same, but it's also how do we try to reach people with these messages, how do we make sure people take care of themselves is one thing, and then when it comes to the more severe mental health issues where the treatment is needed, I think it's important that we ensure that patients do receive this treatment. So first of all, we need to make sure that in these times when it's more complicated to reach healthcare professionals, that we have access to healthcare professionals needed in this field, but then also to have access to the medication and to make sure that the patient can actually receive medication. And I think I was talking earlier about value-added medicines. And there are some very good examples in mental health. If you think about the very severe mental health diseases, for instance, schizophrenia, how can we expect patient that is having an episode to be taking medication in a form of pills of tablets every day? It's almost impossible to adhere to the treatment. So why don't we give this patient something else? Why don't we give them some kind of we have this kind of form with psychotics, where a patient can get this medication and then we work with them and with different healthcare professionals to then get better and then get integrated into societies. So I think this is a very good question. Mental health also means a lot of different things, from being anxious before the exams to a very severe, that can also then turn into very severe issues, but we need to tackle them at different levels and with help of everyone, I think.
Just to say a word from a policy perspective, in fact, there is a need to have a political will for mental health, but for any other public health issue. If you have the political will, you will potentially have a national plan, and thanks to these national plans, you will be able to have in the same room healthcare professionals, regulators, other stakeholders that will be governments who will be able to evolve recommendations, practices, and also to maybe to foster innovations for new treatments, for new applications, and so on. So again, collaboration is key.
Thank you a lot to both of you, and I fully agree collaboration is the key, as this is quite a huge issue. If we can go now to the next question. What problems can occur when vaccination starts in pharmacies with very little preparation because of COVID? Not in France, but in other EU countries. Who would like to tackle this? Yeah, I think, yeah.
I don't know which problems, but the adverse events or another problems. I don't know, that we are prepared to act in case of emergency, and we have to plan. All the services on the pharmacy have to be very well planned, and the problems, we can anticipate all the problems. We know that sometimes something can happen, but if we are prepared, and we are health professionals, and if we have all the information, we have the practice, we have the training, we will act in case of emergency. I don't know if the problems are this or another problems, but I think it's the answer.
Thank you a lot. Does anyone else want to add something on this?
Thank you. Maybe I was wondering about this earlier, so I will take the opportunity. But I know with the vaccines at the beginning, there were a lot of questions about the logistical part. So we know we have different vaccines. Some are stored the different conditions. You need a freezer, you need a fridge, and so on. And I think we had this problem because we didn't have facilities, like these big facilities, vaccination center, that were able to provide these conditions, or we need to think about how to do this. But how is this organized for pharmacies, and is this something that pharmacies have in place?
I only have the flu experience, but we have the vaccines are a medicine like another, the insulin or others that can be on the fridge. Then in COVID moments, we planned the administration. We scheduled all the people. We don't have a lot of people in the pharmacy at the same moment. We can schedule, book all the vaccinations, and I think it's the normal day in the pharmacy. It's not something strange. We only have the different thing. It's only we have to clarify some information to the people about the vaccines in the COVID. I think the information it's to choose between the different vaccines, but our colleague from French talk about this, and I think it's the normal life. I think in the pharmacy.
I think that's so interesting, because we were facing all these issues and learning about them. But then when you listen to a pharmacist, they know how to deal with this in community pharmacy. And I think this is so important to understand that there is all this logistics, that it's very complicated, but a community pharmacist knows how to deal with this and says, this is a everyday life for us.
Yes, thank you a lot. I fully agree with what you said. It's very complicated, but it's not something that people are really aware of.
Sorry, it's only complicated at the first time.
Indeed, after you figure it out, it becomes a bit easier.
Yes.
Just as anything, when you start doing something, you don't know exactly how to do it, so you need to figure it out on the way, and then it becomes easier. It's when you start putting a plan for it. Okay, could you please comment on the anti-vax movement and how the communication can be improved there? I think this is a very touchy topic, so maybe if we can focus on, in general, how we can improve the communication towards the general population regarding the importance of vaccination. Please.
I can just... for me, there's been a lot of communication on vaccination, why you need to get vaccinated, and so on. So probably the communication shouldn't be on why you need to be vaccinated, but to understand what are the underlying reasons, the underlying factors why you don't want to be vaccinated, because there are many studies which have been published explaining why the anti-vax are anti-vax outside of hypersensitivity or medical reasons. And that would be the best approach to me to understand why people don't want to get vaccinated, and without any judgment, because we're not there to convince anybody, even if it doesn't be vaccinated. But we know we are always all been in situations, I think, even personally, where you are at a table with family, with friends, and you have at least one person saying, I don't want to be vaccinated. And you can see that bringing scientific arguments won't work. So the communication shouldn't be on that level, in fact, but again, better understand where they come from, and to not to try to bring them to your place, because they don't want to be convinced.
I think the answer is information, and the information is different between the people that we want to talk. If we are talking with adults, active adults, they have an expectation, they have some concerns, different for the elderly people. And the policies, this is not only a problem for the pharmacist, but in front of the patient in the pharmacy, we have to clarify every day this information. But we have to be in collaboration with the national policy to develop some strategy to the different people, to the different groups of the people, to improve the initiatives and to improve more information. And to facilitate the process, I think the pharmacist is a facilitator, and the results are coming. In Portugal, I think the strategic was to choose a person with experience in logistics, and he defined a strategic to vaccinate first the elderly people with over 90, then over 80, and when it was necessary to vaccinate the young people, the most of the population was vaccinated. And to the young people and the active people, I think it's the groups, the age groups that we have more problems with the misinformation and the groups with anti-vaccines. It's a closed group, and we can talk with them. It's not in individual dialogue, but specific information to clarify their concerns.
Thank you a lot. And maybe as a follow-up question, because in my country, for example, the vaccination rates were very low compared to other countries where the rates were way, way higher. What do you think? In my country, we also tried some strategies, but it didn't really work out. What do you think it was the strategy that worked in your countries or in the countries with higher vaccination rates?
I'm taking this this one for France and especially for the younger population. We've seen a massive rush to vaccination from younger people when they said you will need your vaccination to go to the disco. You need to be pragmatic, and again to understand the underlying factors or reasons which could switch at the mindset.
Thank you. Anyone wants to comment on this? Or then we can move on to
I just think it's very complicated to also draw this comparison between countries in some ways, because we have, I live in Belgium, but I come from Slovenia, are two very different countries with different vaccination rates as well. But there is a certain political aspect of what is happening in the country that contributes to the thing. But then also of how hard the country was hit with the coronavirus, I think, because Belgium had so many cases, a lot of people died. So I think people were much more aware how severe this disease can be. And so a lot more people got vaccinated for this reason. The lockdowns were far more stricter. And so I think there are really different things, and it's really hard to compare countries and what's best and what doesn't work best. And I think, but what we have seen is that it's really important that there is a plan, that is a political plan, and the importance of good governance in this kind of crisis.
And adaptive governance. I think that one of the reasons anti-vax will say, oh, I won't get vaccinated just because the government is not clear about the vaccination strategy. We've seen it with this crisis that the governments have adapted with the latest scientific information available. And of course, this may contradict with what has been done a few months ago. And also the public needs to be aware of that science is evolving all the time. You know that for our pharmacists. And maybe something which was true 50 years ago is not true anymore. Something I've learned at university is not true anymore. And especially with this crisis where with things moving so fast, governments had to adapt their plans with the latest information available. Also to communicate on that.
Only one more comment. Portugal has a big experience and very good results with vaccination. It's not only for the COVID, for the other disease, the tetanus, tuberculosis, and I think this is something easier to administrate a new vaccine. It's easy because the people knows that the vaccines are important for their lives. I think this is a way.
Indeed, thank you a lot for your input. I think it's very helpful, and let's hope in the future things will be better in all countries, not only Europe but all over the world. And I see that participants are really interested in this area. And for example, there is someone asking what could we as pharmacy students do to help with the implementation of vaccination in pharmacies in our country? If you have any ideas.
First, talk about this. I think it's the first step. Then it's important to have some numbers, to know about all the process and how the pharmacists can improve the numbers of this vaccination. And for other hand, I think it's to work about the information about the vaccines, for in the future have opportunities to vaccinate more people. And this question links with the last one. If the people knows that it's important for them to be vaccinated, we have more opportunities to help the people. And I think the students can do this to inform to the new generations the importance of the vaccination, because in the future we will have better results, I think.
Yeah, and to maybe add to this, another perspective is also the advocacy work that EPSA and also national associations can do and are already working on. I know EPSA is involved in the vaccination advocacy as well, and I think this is very important, and also public health campaigns to show that you are a future of healthcare workforce that is interested in supporting this. And so this really, gives a certain image and shows that you are interested, invested in this topic. And so you can work this on European level altogether, but also national level. And I think the second thing that also we've been talking about this today is included into the pharmaceutical curricula. So I think that's another area where you can advocate to include these skills already early on in your education in your country, so then when you enter the pharmacy as a community pharmacist, you have your training already.
Yeah, indeed, thank you. And I see a question very related to this, actually. Someone was curious if you think that we need a low TU level for our pharmacy students to study about vaccination and some courses about how to do it. Because at least in my country we don't really study anything about vaccination, and no one is teaching us how we can actually do a shot or vaccinate someone. So do you think this would be helpful?
It's funny because we were talking about that during the break, that it's surprising that at the European level there is no harmonization yet regarding the cursus. You don't study necessarily for the same years, you won't have the same practical experience at the hospital or in community pharmacies, and you don't learn the same things or not at the same level. So, of course, bringing vaccination to the cursus could be interesting. But there is maybe a broader effort to do in harmonizing already the studies of pharmacies in European Union.
Thank you for this. Maybe now, since we don't have much time left, to change a bit the topic, as I see a question right below for Dr. Selin Segui. How is the regulatory process for approving a medicine that is already in the market, but for a new therapeutic indication?
This is what we call a major line extension, for example, where you will need to bring additional evidence of safety, of efficacy, of course, to demonstrate. So there are already pathways for that.
Thank you. I hope it clarifies. Then I see also a question for Maya. Are the development phases 1, 2, 3, 4 of value-added medicines similar to generic medicines or innovative medicines?
That's a very interesting question indeed. So, what's different about value-added medicines from it's not same as the generic or the innovative, but it's something in between, let's say. So, we have a medicine that is innovative, and then it's a generic. So we've been using these medicines for years and years and years, which means that we have learned, first of all, we have this initial base of evidence that was used to register these medicines. So they're clinical trials, right? Then we have years and years of experience from the use. We have pharmacovigilance data, so we know in fact a lot about it. Efficacy, we know a lot about the safety. So this is the base that we take when we develop these medicines, and this means that then the development comparison to the innovative medicines is shorter. So we have shorter development times, But we still have some additional work to do. So, for instance, in the case of adding new indication, it's still likely that you will have to do a clinical study. You will not have to do phase 1, phase 2, phase 3, but just phase 2 usually. Depends. So, what the problem here is with value-added medicines that it really depends, and we don't have one certain way in Europe how we go about this. So, and we also, Céline talked earlier, we have all the different agencies. Every country has their own national competent authority, and we have European competent authority. So, what we are also trying to achieve is to get this recognition that we need to have more streamlined processes, and we need to understand better what kind of evidence these agencies need, so the development to be more clear what do you need to do in the development. But in essence, it's shorter than the timelines are shorter. There are not all these phases you need to go through because you already know a lot about the medicines as the innovative medicines development, which means that then you can bring to the market more affordable also innovation.
Thank you a lot. I hope it clarifies. Let's see what other questions. I see there is a question with a lot of votes up. How do you make sure pharmacies oblige to the standards of the computer system when it comes to administration of vaccines, for example, COVID?
How I said, we have some requirements to develop the service in the pharmacy. And the records of all data is one mandatory. I think we have the professional responsibility to record all the information, but also we have another responsibility with the patient, with the people, because when we administer one vaccine in the pharmacy, the people receive this information on their bulletin. I don't know the name in English, but it's a mobile record with all the information of our vaccination. I don't know the name in English. It's like a passport, a vaccination passport, with all the vaccines that we in all of our lives has administered for us. But I think it's a professional request for the flu or for the COVID-19 vaccine. I don't know. I think all the people have to do the report. And I saw another question about the capacity of the other countries to develop the service. I think yes, but I have, in my opinion, some of the recommendation that we have in Portugal, it's important, it will be the same in the other countries. The physical, some physical requirements on the pharmacies, the training, and the training for the administration, and also for to act in case of emergency. Some of the recommendations, but each country knows their realities, and I think it's an opportunity, but it's in your hands, students now and pharmacists tomorrow. But I think it's in your hands. I think it's
Thank you. Hopefully we'll be able in the future to do more now that all the discussions are carried out and we all have to learn something from this. And I think the question in the middle might be a bit related to this. How would you improve communication and advocacy strategy to involve pharmacists and students earlier and better in the COVID vaccination campaign, but maybe I would say in general vaccination campaigns, because now it's COVID, but in the future might be something else. If anyone has any ideas.
I know I always come back to the same things, but put the people in the room, put the different professional organizations in the same room, and talk about what you expect about the profession, what you expect to do, and what role you want to play in the vaccination, for example.
Thank you. And as I see the time for panel is almost ending, I would like to address one last question, which I think it's a nice way to actually end the discussion. As future pharmacists, we want to improve ourselves. What do you recommend students and recent graduates to help them become better professionals?
First, our background is about the medicines, and we never lost this because we want to develop some surveys, to talk with a lot of things, but our background is the medicines, the drugs. And we have to be at balance at all moments about this. And then we can choose that we really want and we really like. But we have a lot of ways but if you are in a community pharmacy, I think it's important to know about the therapeutic, but also the pathology, but also, and this is important, and we have to improve the knowledge of the pharmacies about the health policies, about how can we together improve the interventions of public health. I think it's one of the one way, but you have a lot of ways. Depends of do you want for your future.
I would say just put the patient at the center of everything. Don't forget that you are here for the patient. Maybe for many years, all the stakeholders in the pharmacy ecosystem maybe have lost the patient of sight at some point, and now it's coming back at the center of everything. And be pragmatic, know what you are doing, why you're doing it, and also something that the CEO of the company I'm working with is always saying, use facts as your friends. If you're saying something, you need to understand what's behind, if there is any scientific data behind. Like we've talking about vaccination, but it can be anything about mental health or whatever. And again, collaborate. Grow your network, very important. We were also saying that during the break. It's quite impressive that you are so involved, you are attending this congress. I wish I had been more active in networking when I was younger. Maybe I don't know, a different career, but having a great network allows you to understand what a pharmacist can do. With one diploma, you can do so many different professions, and to learn, just fantastic.
Yeah, and that really goes well with my point I wanted to make, which is get involved in EPSA. So that would be my recommendation. So you're already here. That's a very good first step. The next step would be to get actively involved in the organization or your national or local organization. Because I think for me, if I look back, this has been such an important part of my growth. And it really gives you this great ground to try different things, to learn, to work with people from all over Europe, from different countries, meeting different cultures, understanding the work environment. I think this is so valuable, but then also being able to try some things, to organize a project, gives you all these skills that you will need in your career later, wherever you end up. So this would be really my warm recommendation, get involved.
Thank you a lot to all of you. I fully agree. Get involved. It will help you a lot. I'm not yet such a high professional as our speaker, but for me also it helped me a lot getting involved in general in EPSA and in any type of association. And you will understand it later. So with this, we end our panel discussion. Thank you a lot for joining us today. Thank you a lot for your amazing presentations and for staying here with us to answer the questions from students. So yeah, we're delighted to have you here with us. And we'll move on soon with some presentations for some students. But first, yes, a round of applause for our speakers. Thank you a lot, Marina. Please, we didn't finish yet the symposium. Now, as you know, we opened the call a while ago for some students who will be interested to actually present their work here in front of all of you, and we received 3 applications. So now the 2 of them will have the chance to show you what they've been working on. And I invite the first one here on the stage, which is Theodora Russov. She will be presenting you something, a presentation called The Family for Community-Acquired Bacterial Pneumonia. So please.
Hello everybody. My name is Theodora Russo. I am 23 years old. I am from the University of Patras, Department of Pharmacy. And we are going to talk about lefamulin. Lefamulin is a drug. It is used for treatment of community-acquired bacterial pneumonia. Here are the contents of this project. First of all, lefamulin with brand name Heleta, first approved on 19th of August 2019, and the dose form is tablets and injection from the company Nabrica Therapeutics for the treatment of adults community bacterial pneumonia. First of all, it is a plevromethylene. Plevromethylines were discovered many years ago, but those two, thiamulin and valenulin, 1979 and 1999, were antibiotics for animals. Later, in 2006, Heleta was discovered by this company, Nabriva, which in 2018 announces positive top-line results from phase 3 about the oral lefamulin. And in 19th of August 2019, FDA approves it. But what is this community-acquired bacterial pneumonia? Okay. It is the number one cause of mortality in India and worldwide. And it's caused by those microorganisms, Streptococcus pneumonia, Staphylococcus aureus, Haemophilus influenza, and Legionella pneumophila. It is something that goes to a person who does not live in a nursing home or has not been hospitalized for up to 2 weeks before the onset of those symptoms. As we can see, it is more often to men than women, and at the age is 19 plus. This is the formulation we can find on the market. Those are the pills, and this is the injection. So, lefamulin with this brand name Henleta is a recently developed antibiotic for the treatment of bacterial community-acquired pneumonia, CABP, in adults. It's plevromutilin. This is a plevromutilin with this formulation, and this chemical formula you can see there. Lefamulin, as we have said, is available in intravenous and oral formulation. About injection, supplied as a sterile injection for intravenous use as a clear colorless solution in a glass vial containing 150 milligrams of lefamulin. Tablets for oral administration are available as blue oval film-coated tablets, equivalent 600 milligrams. The class of plevromutilin antibiotics has been veterinary basic medicine for decades. This that made this drug special, it is the first antibiotic in the class of plevromutilins, which is available for human use. Okay. So about the chemical synthesis, it is this is the laboratories in Vienna where it is. Where we can see the process. And some about the lefamulin. The Tmax value was measured 1 hour for intravenous administration and 1.76 hours for the tablet. It is a small molecule type. And the plasma protein binding of lefamulin is a high percentage. If someone thinks that the plasma protein binding generally is this. CYP3A4 is the main enzyme responsible for the metabolism of lefamulin. And this C14 carbon is responsible for its optimum properties. About the mechanism of action, lefamulin is a tricyclimutilin core in the common for binding of all members of its drug class, the plevromutilins. Although this tricyclimutilin core doesn't form any hydrogen bonds with the PTC nucleotides, it is established or anchored by hydrophobic and van der Waals interactions. And this is a summary. with the brand name Enleta. It is investigate on 206, but is approved from FDA on 19th of August to 2019 with the ID BC 3781 by the company Labrivo. It is in 2 dose forms, tablets and injection, and it is used for treatment of CABP. Some future plans. It has found that the lefamulin may be used about treat other some other treatments such as sexuality transmitted infections, osteomyelitis, infection in prosthetic joints and others, but it is in preclinical studies about those. For now it is only treated CABP. This is my bibliography, and thank you for your attention.
Thank you a lot for your presentation. Now let's move on to the next presentation, which is Ines Lorenzo. That will talk about antimicrobial resistance in the Faculty of Pharmacy of the University of Lisbon.
Hello everyone, I hope you are having a great Congress. And now I will start my presentation on the topic where I developed my research project last year. That was about colonization and microbial contamination of public restrooms by multi-resistant gram-negative bacteria in my faculty by the IMED Lisboa. So first of all, let's clarify the pillar concepts of this whole research, that is antimicrobial resistance, or AMR. It is the ability of bacteria to combat the action of one or more antibiotics, and this is the main health concern in European space, since every year in Europe it causes 670,000 infections, from which results 33,000 deaths. For you to have a grasp on what this number represents, it is the equivalent of the fall of 100 commercial planes every year in Europe. Imagine this quantity of people dying every year. If it was from plane crashes, the attention to this problem would be much higher. The species that cause most concern are the famous escape, and you should really try to escape from them because they are the cause of those numbers of deaths. I won't bore you much with all the theory behind antimicrobial mechanisms resistance, but I'll just talk to you about the 3 main ones that are restriction to antibiotic access to the targets, that the bacteria can change by changing its permeability membrane, by adding or taking out porins, so by that it can change its permeability, or with efflux pumps. There are transporter proteins that can efflux the antibiotic, thus losing its effect. Secondly, we have target modification, and it is the case of PPPs, penicillin binding proteins, that are very important in Staphylococcus aureus resistant to metacycline. And by last, we have drug inactivation. This drug inactivation is often made with different enzymes. We have the most common ones, bactalactamases, and inside that group we have extended spectrum bactalactamases that you've probably heard of and are quite worrying. and carbaminobases. And then you have enzymes that modify aminoglycosides and fluoroquinolones. But what are the causes to this big issue? First of all, inadequate use of antibiotics and their prescription. We should only prescribe them when necessary, and there is also insufficient control and prevention in hospitals with contamination by these bacteria. Chemotherapy in oncological patients, since they are very debilitated in their immunologic system. Climate change, and agriculture and aquaculture, by what you probably expected, the consumption of large spectrum antibiotics. But who is responsible for changing? Who are the main drivers for this problem to disappear? The answer is quite simple, actually. It's all of us. All of us, from patients to doctors to nurses to vets to farmers to policymakers, and last but not least, the pharmacist. Either it is in community pharmacy, in the dispense of medication, or in its vast areas of action. The cost to this problem is very high, not only in humanitarian lives, as we saw beforehand, but economically. Death and disability result in longer hospital stays that result in more expensive medicines for patients and therefore causing financial challenges not only to the systems of health but mainly to the patients that often cannot afford these treatments. For you to have a better grasp on this, the cost to the economy of AMR is the same of AIDS, tuberculosis and the influenza combined. But there are still solutions, and there's a way to go to mitigate this problem and to guarantee that antibiotics stay effective and working in the near future. Those solutions are using antibiotics prudently and only when necessary, good infection prevention and control practices, and promoting research and development. So what did I do in the lab? I collected 8 samples from my faculty in Lisbon, I isolated them, tested their drug susceptibility, extracted the DNA from the species that looked more interesting, amplified that DNA through PCR so that I could analyze it with bioinformatic programs. All of this to reach these 3 main goals, to answer these questions. Are there resistant gram-negative bacteria in my faculty? If so, what are the species and what are their drug susceptibility profiles? And yes, I know what you're probably thinking. I was swabbing for mornings, toilets, taps, and the sanitary brushes from my faculty. But I think that this effort was not in vain because we came up with very interesting but also very concerning results. And the results, firstly, were that there was no contamination in the toilets or in the taps, which was great. They were impeccably clean and like the sanitary brushes. In those objects, we found 7 multi-resistant bacteria belonging to the orders Enterobacteriales and Telemonalis, these last ones with higher intrinsic resistance, as you can see. But the isolate 2, there is an Enterobacteriale, was noteworthy of our attention due to its resistance profile, the accessibility. It showed concomitant resistance to this set of antibiotics, so we could conclude that it probably had the variant of CR acetyltransferase that can be transferred to horizontal gene transfer, and a bactalactamase of large spectrum, the CTXM15. These 2 enzymes can destroy or modify the antibiotic, losing its effect. This is especially warning because Klebsiella is one of the most concerning bacteria in nosocomial infections, and it can cause infections from the urinary tract to bacteremia to respiratory diseases. So what did we conclude from this pilot study that I'm still continuing this year? That the use of public restrooms can be a source of transmission of multi-resistant bacteria that can colonize the digestive tract and make us sick and potentially die if you are immunocompromised. That it is needed extra attention to the use and disinfections of these restrooms, And I don't want to be polemic, that my faculty should review its cleaning processes and teams. Thank you all. For my Portuguese colleagues, you can scan the QR code and have access to the poster that I made about this topic. It is in Portuguese, so sorry for all the rest of the people. And thank you so much for your attention.
Thank you so much, Ines, for your very interesting presentation. Guys, we have one more. So our last student that will be presenting something today is Jan van Ermingen. He will talk about the influence of sex and isotype on the humoral immune response. The floor is yours.
Thank you so much. So for a quick introduction, my name is Jan van Ermingen. I'm a pharmacy student from the rainy city of Kiel in Germany. And today I'd like to talk to you about the topic of immunology. We've already heard stuff about the role of pharmacists in vaccination programs from the previous speakers today. So I think since they have covered that in depth, I don't really want to get into that too much, but cover this topic from a different angle. And that angle is that I want to talk about the research in immunology. And if you go out of this room today, my goal is that you have a feeling for how new results in immunology, new findings in immunology could transform and change the way we look at vaccine development. In the course of my presentation, I also want to tell you something about the research that I have conducted myself during my research internship at the fabulous university ETH in Zurich, Switzerland. Okay, so without further ado, let's get right into it. Okay, sorry. So, I think we've all been relieved by the huge success of the COVID-19 vaccines. If you are vaccinated against COVID-19, you have a very, very tiny risk, or a very small risk, to get affected by COVID. And that's the reason why we can all be here, meet each other, and have these nice parties in the evening. But, however, following a vaccination, as an interesting meta-analysis shown that came out just a few months ago, following being a vaccination with a COVID-19 vaccine, men have a 33% reduced risk of getting an infection with COVID compared to women. The reason for this, to make it brief, we don't really know. But what we do know is that this indicates a difference between men and women when it comes to the immune system. So, I think some of you are probably already familiar with this. So, talking about the immune system, it's a very complex system. Very many players interact with each other. So, if you want to get a better understanding, first you have to pick your field what you want to look at. In our case, we have taken a closer look at the humoral immune response, and more specifically at the IgG response mediated by B cells. So the reason, well, we have looked at IgM, IgG1 and IgG2. IgM is for the primary immune response, and IgG1 and IgG2 are the secondary immune response, which are also giving you the long-term immunity. And the reason why we have looked at these specific isotypes of immune globulins is, first of all, B cells or mages are just the coolest class. Don't get me started on this, but I think some of you maybe can relate. Harry Potter, anyone? Yeah, and the second not so obvious reason is that we want to have a closer look at the long-term immunity caused by, for example, vaccines, and that's also the reason why IgGs are being used, or the titers of IgG in the blood are being used in many cases to assess the efficacy of a vaccine, so how effective a vaccine is in the development. So with it here, I basically just want to show you that it's already a known fact that there are differences in the immune response between men and women. Researchers have found again and again over the years that throughout basically all different immune globulins, there are significant differences between men and women throughout all the ages. Let me just take this off. So here we can see that even 50 years ago, researchers have found differences in IgM, significant differences between men and women. And knowing all this, that there are differences between sexes and also in vaccinations, it also kind of makes sense that, for example, women are far more susceptible to many immune diseases, in fact, to almost all of them. But men, on the other hand, are much more susceptible for severe causes of diseases such as COVID-19, because the immune response of women is just much stronger compared to men. Okay, so well, how did we actually take a closer look at the immune system? For this, we used the DropMap technology, a technology that was built by the working group I did my internship at the ETH. And it's basically a kind of assay that works through microfluidics. I don't really want to get too much into it, but I really want to show you the nice shapes of these microfluidic droplets. So I think the reason why you do this, why you try to encapsulate cells together, as you can see here, together with different reagents for your assay, is so you can look at each cell individually. So usually you would measure a titer in blood, but here you can look at each cell because you have these small compartments. If you now ask what are these weird lines here, that's what we would call a bead line. That's basically a vertical aggregate of magnetic nanoparticles, and I'm just going to explain why we're actually using them. It's not as random as it seems. So we have kind of a problem where measuring in these very small volumes, because it's kind of hard to get enough reagents in there to do like an enzymatic reaction. So we use fluorescence detection antibodies, and similar to like a COVID antigen test, we need to fixate them somewhere, because otherwise we'll just have these red bubbles as you see on the left. And now we have these nice bright lines as you see on the right when we have a positive result, when you actually have the antibody. Many of you are probably familiar with this concept from something like ELISA. Here you see how this is going to work. So in the middle you have the antibody we want to detect, and there we have the detection antibody. Okay, so for my assay I use different reagents. I don't want to get into much detail here, but basically I was able to detect IgG, differentiate between IgG1 and IgG2, and also measure the affinity of my IgGs. And here you can see such a nice picture. So you can see here we have many cells that we screen at the same time under this fluorescence microscope. And up there, the bright line, you can see an IgG positive cell, as well as also down here. So, looking at the time, I should probably get to my results. So I know this might look a bit overwhelming at first, but let me try to explain what this here says. So first of all, here we have a kernel plot, which is basically a histogram with tiny pieces. So we see the distribution of the B cells, the affinity of the B cells between male and female. Log KD means basically the affinity. So the more negative the log KD is, the more to this side, the more affine the mediated antibodies by the cells are. And I could talk about the difference between the male and female mice, but that will be kind of boring, because we've seen something really interesting at first. And I was, to be honest, convinced that I somewhere made a mistake and had to start all over again. As you might have noticed, IgG1 here is more affine compared to IgG2 and IgG3. And the reason why this is kind of counterintuitive is because IgG1 in mice is known to actually inhibit the immune system. Whether IgG2 accelerates the immune response and also, well, kills any bacteria or viruses or whatever the antibodies are secreted against. So what does it even mean? Why would that matter? Well, just imagine you give someone a vaccine and it induces a huge immune response, and you measure the titer, as I mentioned before, to assess whether the vaccine is good or not. And you have a very high titer. You think, oh yeah, this is a very good antigen or whatever to formulate a vaccine. The only problem here could be that you actually have lots of IgG1s, which have no function at all. And then you have a second candidate, and that one's induced something we call isotype switching, from IgG1 to IgG2, which is very beneficial for the immune response, since IgG2 is, since IgG2 actually supports the immune response, in contrary to IgG1, which has this inhibitory function. So, to wrap it all up, you could hardly misevaluate the difference between a good and a bad antigen for a vaccine if you don't take into account the isotype. At least that's my hypothesis that I can conclude from my research findings, and I think it's going to be very exciting whether this can be proven again in further studies. Okay, my time has run out. I thank every one of you for your attention, and I also want to thank everyone who has supported me on my long journey. And if you have any questions, please feel free to ask them or approach me throughout the next days. And yeah, we will see each other in the social program. Thank you.
Thank you a lot for your presentation. Now that we have a bit of time left, if any of you has any question for any of the three students, we have some time, so if you're curious to find out more, I'm sure they'll be happy to answer. Just raise your hand in case you do. Okay, I don't see any. So thank you a lot for being with us today. Thank you to our speakers for being here in front of us. Thank you to our students who took the chance and were brave enough to come in front of all of you and present their research papers. And thank you to all of you who engaged with us with questions on panel. I hope you enjoyed this session. I will have some very small updates or requests for you before you're leaving. First thing is that please look around, not now, after I finish. If you see some glasses that are not yours, and please inform the Czech delegation in case you find them. The second announcement would be regarding lunch. Please, if you signed up for some dietary restrictions, please respect that and take your meal, because yesterday we had to throw away some of the meals because they were not picked up, and we shouldn't really waste food. The lunch will be only ready at 1, so please do not push helping team or anyone else. You will have time to go for a walk, go outside, take some fresh air, but please do not try to be there before 1 and push the helping team. They are really doing their best to have everything ready in time. If you signed up or if you're interested to be scrutineer or meeting secretary for the GA, there is a meeting right after Symposium in the front of Symposium Hall. You can find there Marlene that will help you with more information and will prepare you for the GA. And last update would be, if you still want to register for the RX EPSA session on Saturday, please feel free to fill out the Google form. It is on the Facebook participants group. So thank you all. This ends our session today. I hope I'll see you at the rest of the educational activities, and I hope